Hi, everyone. Thanks for joining this journal club. I will wait another couple of minutes to see if another couple of people are joining. But in the meantime, you can scan the QR code or go to the website polev.com /Emmanuelle Butty 890. We're just going to start the presentation with a little quick poll since we have, I think it's always interesting when we have a meeting of people like that to see what everybody is doing. So I will take the chance to have all of you here to join the poll. Thank you. Great, so let's slowly get started. My presentation didn't want to connect with the poll, but that should work like that. And so this will be the first question today before I start talking about the article. But I was interested to know for all of you, when are you starting anticoagulation in your PLN patients? Is it in all your PLNs? When your patient has an albumin below the reference range, when your patient has a UPC at a specific level, typically like an example here above 2, when your PLN is hypercoagulable on a TEG, or where it has evidence of thrombotic disease, or are you never really using any anticoagulation in your PLN patients? Or if you have any other input, you can always add that in the chat. So we'll give you a minute or two. And let me know if there's any difficulties, but I can see that people are starting to give their input. Thank you for your participation. Great, so we have 11 answers so far. And things are stabilizing. So let me see what people answered. So the majority of people answered when my patient has an albumin below the reference range. Otherwise, sort of similar in all my PLN and when my PLN has evidence of thrombotic disease. A couple of people are only using it when the UPC is higher than a specific amount. And I don't know for whoever is using other, if we can add a comment in the chat. But I wanted to add things, add another in case somebody had another way to decide when they are starting. So very interesting. So here, the majority are using it when, depending on the albumin level. And then my next question for you is, which type of anticoagulant are you using on your PLN? Are you using an antiplatelet like clopidogrel or aspirin? Are you using unfractionated heparin or subcu molecular weight heparin, such as enoxaparin, or an oral anti-10A like rivaroxaban?
Use both. I guess that would be other, huh?
Oh, yeah, let's select multiple.
You can select multiple if you're using multiple, Mary. Great. So let's see the answer here. So the large majority, very interesting, is using clopidogrel, and a couple is using clopidogrel, and a couple of people are also using rivaroxaban, but no aspirin, heparin, or low molecular weight heparin. Very interesting. And let me just check the chat. So JD is the other, doesn't use albumin, UPC to distract when to start, prescribe it in most, usually without tech testing, but sometimes I'll run it. I don't believe albumin, antithrombin activity, or UPC accurately predicts risk of thromboembolic complication. Great. So that would be part of like the first in all your PLN, which I'm kind of the same. Very interesting. Thank you everyone for your participation. I always think that, especially when we talk about things that don't necessarily have black and white guidelines and black and white, everybody's doing the same. It's always interesting to have a meeting of people interested in the subject to kind of know what they are doing. And we'll use that for the discussion at the end. But back to our article today, we'll be talking about factors associated with thrombotic disease in dogs with renal proteinuria. So this is an article that was published in JVIM, and it comes from the Royal Veterinary College. And we have these two authors, Dr. Fortuna, who, at least from my little research, did his rotating internship at RVC. So he may have started the paper during that time, and supervised by Dr. SAIM. So these are the two authors that came up with this JVIM article that will be discussed today. So as a little introduction, they are talking about what is protein-losing nephropathy, so a damage to the glomerular filtration barrier. And so this allows plasma protein to cross into the filtrate in excessive quantities, and so they end up lost in the urine. And so we know from a couple of studies already that PLNs are hypercoagulable in vitro and at risk of thrombotic disease. So they are talking about these three references here. The first one showing that PLN dogs compared to a control population are definitely hypercoagulable. This other study talking about or describing PLN dogs and noticing that 22% of them had thromboembolic complication. And they are talking about this most recent curative guidelines, talking about PLN associated with the development of thrombosis and the recommendation of starting antithrombotic therapy for dogs with PLN. What is interesting, though, is that there's definitely limited work on additional risk factor for thrombotic disease among PLN dogs, and this is what the author got interested to describe. They're also talking about the fact that despite the guidelines that we have, so we can see here the guidelines from the standard therapy of glomerular disease in dogs and the curative guidelines, that PLN dogs are predisposed and it is recommended to start antithrombotic therapy, but we don't really have great studies to show really the evidence of the benefit from it. So we have these two prospective studies here on the association between all the clinical pathological parameters and the TEGS results in PLN dogs. And so the first one showed that the PLN dogs were hypercoagulable compared to the control population, but they also showed that antithrombin, albumin, or UPC could not really be used in isolation to predict these results. And the second TEG paper here was describing the findings in dogs with PLN, and 89% were hypercoagulable. Only 6% in this study had evidence of thromboembolism. And they also found that the degree of proteinuria, systemic arterial hypertension, hypoalbuminemia, or low antithrombin activity were not really, could not really be used to predict these results. So they are also describing that, or at least quickly mentioning that the protein C levels in PLN dogs are higher than in normal dogs. That has been shown in a study, but it's of uncertain clinical importance. And I think they may be mentioning that in the introduction because one of their points is that TEG is not necessarily available everywhere. So that could be one of the tests that is run as well. And so regarding the thrombus location, PLN dogs are most commonly described to cause a pulmonary thromboembolism, described in the curative guidelines. In human medicine, we know that the pulmonary thrombi are considered to be venous in origin. In the veterinary medicine world, we don't really have this distinction between primary pulmonary thrombi and thromboemboli from the systemic venous circulation. But it is thought that primary venous thrombi are less common than in humans. And we also have reports that aortic thrombi are definitely a thing in dogs with PLN. We have this study from 2020 that showed that of 32 of all the aortic thrombosis that they described, 32% were PLN patients. So definitely a high risk population here. And so for the author, they had this question of, is there any different risk factor for developing a pulmonary thromboembolism or a venous or arterial thrombotic disease? And so within this population of dog with PLN. And so if we are able to answer this question, we could potentially help target an optimal prophylactic treatment. That being said, when we talk about prophylactic treatment, we were, as we discussed I was trying to show during like this little poll, we can use antiplatelets, we can use anticoagulant. Theoretically, one should be used for arterial and the other one for venous, but there's definitely a crossover as well in human medicine, and that is demonstrated to help with the prevention of this thrombotic disease. So not necessarily as black and white, which one has to be used for which complication. And so the objective of the authors were really to look at clinico-pathological and signalement variables and to look at them in a group with thrombotic disease, one without, and also for the group with thrombotic disease, was it, seeing if there is any difference between thrombotic disease in the pulmonary circulation or in the systemic venous or systemic arterial. So that was their objective. And for that, they did a retrospective case control study, looking at cases that presented to the Queen Mother Hospital for Animals between January 1st of 2004 and 2021. Their inclusion criteria was really for PLN, was 1 UPC above 2 without pyuria, bacteriuria, pigmenturia, or gross hemorrhage. They don't really talk about exclusion criteria. That was how they sort of came up with their list of PLN patients. And the PLN with thrombotic disease, it was based on if the thrombotic disease was visualized on diagnostic imaging or during a postmortem examination. And they also included the one that were suggestive but not conclusive on imaging findings when they were present with when other alternative diagnoses were excluded. And so typically it was an acute onset of dyspnea with no changes on thoracic radiographs, if there was any evidence of pulmonary hypertension on echocardiography, or if the patient had any hypoxemia. And these patients with thrombotic disease were further classified in venous, arterial, and pulmonary thromboembolic disease. And so when there was more than one location, they excluded these patients for comparison between thrombus location, but they still kept them to make a difference between patient with or without thrombotic disease. And so to select, once they had their population with thromboembolic disease, they searched for the patient without it. And how they decided to do that, they used their entire chronological list of patients with a UPC above 2. And every time they isolated a patient with thrombotic disease, they basically took the patient before and after the one that had thrombotic disease. And that's how they selected their population without thrombotic disease. Hopefully that makes sense. And obviously, don't hesitate to interrupt me if you have any question in the process. So for all of this group, they looked at the signalement, including age, breed, sex, and neuter status. For the breeds with less than 5 cases, they just classified them as small other breeds if they were less than 15 kgs, or large other breeds if they were above 15 kgs. And sighthounds breeds were combined into one big group. They looked at the comorbidities of this patient, looked at their UPC, their non-invasive blood pressure. And they also looked at the hematology and biochemistry when it was available. And they have a little note on the fact that they didn't necessarily include the platelet count because the majority of their cases had platelet clumping. So they thought that the platelet count was not really reliable, but they looked at if there was any absence or presence of platelet clumping on their CBC. A couple of things that they don't necessarily specify in the method was the renal histopathology, because they talk about biopsy results in the results, but it's not necessarily clear. Was it just post-mortem biopsies, or was it a comprehensive pathologic evaluation that we know have thinner sections and use all these different staining and electron microscopy and immunofluorescence to really have a full picture of the reason for the glomerular disease in this PLN patient. So no real details on that. They will be talking specifically about AKI as comorbidity, so they don't really describe neither how they define that. They will be talking about antithrombin, but they don't necessarily talk about that in the method neither. And we will be also talking about not only comorbidities, but oral glucocorticoid therapy. So that's all the things that were not present in the methods. But jumping into the results. So if we look at first the thrombotic disease cases, if we look at all the cases that they pull up from their database that had a UPC above 2, they ended up with 478 cases, and they had to rule out all of those that had no thrombotic disease. And so they ended up with 84 at first, but 34 of them had to be excluded. And they're describing the main reason why. Generally, it was because of a lack of urine sediment exam or an inconclusive imaging, or a concurrent UTI. So that made them end up with 50 cases. And it was 6 male entire, 3 female entire, 19 male neutered, and 22 female neutered. And they're also describing in this specific population where the thrombus site was. So they had 57 different sites, and by far the most common were the aorta and the pulmonary vessels. So that was for the thrombotic disease cases. Talking about the comorbidities of these cases, a lot of them, about 3/4 of them, had comorbidities. So they are listing all of the comorbidities that they had. Eventually, in their analysis, they sort of mainly looked at MMVD, AKI, hyperadrenocorticism, pancreatitis, adrenal masses, and all the neoplasia. So these are the comorbidities they're going to focus on. But again, 75% of the cases had other comorbidities in this thrombotic disease group. Regarding the renal histology, 16% of the cases had renal histopathology, and 3 of them were diagnosed with lymphoplasmacytic nephritis, 2 with glomerulosclerosis, 2 with membranoproliferative glomerulonephritis, 1 membranous glomerulopathy, and 2 had no clinical relevant lesion scenes. And interestingly, 10% of the cases that had a diagnosis of proteinuria before they were presented for a thrombotic disease at their hospital, and none of these cases were on antithrombotic at that time. So that was for the thrombotic disease cases. For the non-thrombotic disease, they didn't look at all of them. Again, what they did, if you remember, is they took all of their thrombotic cases and took the one before and after. So that's why they ended up with twice as many cases as the thrombotic disease cases. And there was sort of no significant difference in their population regarding sex and neuter status between their two groups here, thrombotic or non-thrombotic disease. And for this group, the comorbidities were even more frequent. Almost all of them had a recorded comorbidity. And again, they ended up taking at the end just these main comorbidities and looked into those. But we definitely have other that could be really affecting the results. You know, we had IMHs in both groups, for example. So definitely things that could have affected the outcome and be part of the reason for these thrombotic or non-thrombotic diseases. And for this group, even less cases had renal histology. But for the 7 cases that we had, 3 had glomerulosclerosis, 2 with interstitial nephritis. There was a mild thickening of the Bowman's capsule, 1 with severe amyloidosis, and 1 with membranoproliferative glomerulonephritis, and a glomerular vasculopathy. And so that was the results for each group. And then one of the big goals of this publication was to compare both group thrombotic and non-thrombotic disease. And they actually, looking at the breeds, found out that Cavalier King Charles Spaniel and Sighthounds were definitely overrepresented in the thromboembolic disease group, but there was no sex or neuter status predisposition. And again, looking at the comorbidities that they investigated, MMVD, AKI, hyperadrenocorticism, pancreatitis, adrenal masses, and all neoplasia, only the AKI was more common in dogs with thromboembolic disease. But there was no significance, no statistical difference in the prevalence of oral glucocorticoids between the two groups, and no difference in the platelet clumping either. Digging a little bit more into what else different did they found between the two groups. So what they realized is that albumin was lower in the group that developed thrombotic disease. The potassium and calcium were also lower. And the eosinophils were lower, but monocytes and neutrophils were higher. So that was the difference between these two groups. Interestingly as well, you know, just to sort of assess what was their study population, when we look at the creatinine, it's definitely the majority of them, even if we look at the highest ones, didn't have like a severe AKI. And if we look at their UPC, interestingly, the UPC was not different between the two groups. And their UPCs were also definitely a population that could be different from place to place. And I have the feeling that we definitely see some things that are much worse than that. So I was a little bit jealous of their population here. But looking at just these two groups on, you know, looking at each value, they then did a multivariable logistic regression analysis to see what would still be significant. And they found that albumin and eosinophils were independently and negatively associated with thrombotic disease. The neutrophils were positively associated with thrombotic disease, and only the Cavalier King Charles, not the Sighthound, were still independently at increased risk of thrombotic disease in this population of dogs. And they quickly also mentioned antithrombin here in the article. That was they just had a couple of cases that were tested, 7 in the thrombotic disease and 4 in the non-thrombotic cases. And it was almost always within the reference range, except for 1 case in the thrombotic disease group. when we look now at the comparison between thrombus locations, so before we were comparing both groups, now within the thrombotic disease group, these 50 cases, they are looking at where the thrombi were located, and they had to exclude 5 cases because they had multiple locations, but for the remaining cases, they had 10 venous, 24 arterial, and 11 pulmonary thrombi. And that was the different site that they described previously in the article. And looking at the breeds, they sort of mentioned that the Labradors were more associated with pulmonary thromboembolism, while the miniature Schnauzer was more at risk of having venous thrombi. And to continue, what were difference between the location? If we look at the age, the dogs with an arterial thrombus were definitely older compared to the one with pulmonary thromboembolic disease. The albumin was also definitely higher if we compare the arterial to venous at 2.73 compared to the 2.17 here. And the cholesterol was also found to be higher in the venous group compared to the pulmonary thrombotic disease. These are kind of the similar finding like in box and whiskers plots, but this represents the same idea. The albumin level was definitely higher than the albumin was higher for the arterial group than the venous group. The patient with arterial or venous were older than the pulmonary thrombus, and here the cholesterol here is shown to be higher for the one that had a venous thromboembolic disease. And so for the discussion, going back to the breeds, this was kind of a surprise of this article that Cavalli King Charles with renal proteinuria had a higher rates of thromboembolic disease compared to other breeds. These Cavalli King Charles have been predisposed to aortic thrombi, but especially aortic, but it has not been associated with PLN up until now, and they are not necessarily a breed recognized to have a particular breed-related cause of PLN. But 5 out of 5 dogs of this breed with thrombotic disease in this study had an aortic thrombi. And one case also had pulmonary thrombi as well. And so the breed was not, what is interesting is that when they looked at the different location, despite this finding, the breed was not significantly associated or a factor associated with the thrombus location. And they are discussing the potential genetic predisposition for Cavalli King Charles Spaniel for thrombotic disease with their connective tissue disorder. It is a subset of the breed that can have increased platelet reactivity, and they are also at increased incidence of cardiac disease. They are talking about the fact that 4 out of 5 of this patient with thrombotic disease had mitral valve disease. So definitely a common comorbidity in this breed. But the cases in the non-thromboembolic disease cases also had mitral valve disease, and it's not necessarily considered a risk factor for thromboembolic disease. So sort of a point to make that may definitely have been related to the PLN and not necessarily their heart disease. Regarding the sighthounds, so they had group greyhounds, lurchers, and whippets together. They were associated with thromboembolic disease when the breed was considered in isolation, but it was not associated anymore in the multivariate analysis. But interestingly, 6 out of 7 sighthounds in the study had arterial thromboembolic disease. And we know that greyhounds are overrepresented in case series of aortic thrombosis. And it is unclear if there's a difference in the underlying renal disease or if it is a breed-related predisposition. And since we don't have histopathologic diagnosis here, the study definitely couldn't make the difference, but something that they sort of found out in looking at this data analysis. And so they also discussed the fact that greyhounds have the predisposition to cutaneous and renal glomerular vasculopathy, but none of the cases with thromboembolic disease in this study had this disease diagnosed. Regarding the comorbidities, there was definitely a ton of comorbidities for each group, and the only comorbidity that they specifically looked at and that was overrepresented was AKI, but that did not remain significant in the multivariate analysis. So AKI has been associated with an increased risk of venous thrombosis in people with nephrotic syndrome, but it's not necessarily something that we have described in veterinary medicine. And there is definitely like a variety of comorbidities in PLN dogs, both with and without thrombotic disease in this study. So that's what was hard to assess. And definitely, since we had so many comorbidities and a small amount of patients for each, the study could have been way underpowered to find any significance between the two groups. And they had a particular interest in hyperadrenocorticism, since it is known to increase the risk of thromboembolic disease. And what was unexpected is that hyperadrenocorticism in their study was associated with thrombotic disease. And so one of their discussion is that perhaps there was a selection bias, that hyperadrenocorticism was more frequent in the no thromboembolic group because it was not necessarily investigated. We may not necessarily have had a UPC, and that's why we may have missed it. Regarding diabetes, that was also more common in the no thromboembolic group. It is associated with proteinuria in dog, but not reported to be a cause of thromboembolic disease. And in human, at least, we know that diabetes is associated with that, but not necessarily with PLN. So a little discussion here on why potentially diabetes and hyperadrenocorticism were more common in the non-thromboembolic group. And regarding the albumin, thromboembolic disease was associated with a lower serum albumin concentration. So we have some previous study that showed that, but not all of them. And what we have to be careful is there's definitely a large overlap in albumin concentration between dogs with and without thromboembolic disease. So we really have to be careful extrapolating these results. And if we look specifically at those results, if we look at the serum albumin concentration below the reference interval, 73% of the cases with thromboembolic disease had a low albumin, but it still means that a quarter of them had a normal albumin and they still had a thromboembolic disease. And 38% of the cases without thromboembolic disease had low albumin levels. So definitely not a clear cut here, and sort of probably emphasizing the fact that albumin cannot just be used to know which one is going to develop a complication. They found that if we try to differentiate between thrombi location, the albumin was significantly lower with venous thrombi than arterial. And so that could potentially suggest that hypoalbuminemia is more important in the pathogenesis of venous thrombus than arterial. And in humans, with nephrotic syndrome, we know that hypoalbuminemia has been identified as a risk factor, but not necessarily in all studies. And it hasn't been associated with arterial thrombi. So sort of a similar results here in human patients. And if we continue to talk about this association between thromboembolic disease and hypoalbuminemia, they looked at this antithrombin activity level, and they showed that only one was below the reference range. So there's, again, another element here that proves that there's no real association between low antithrombin activity and thromboembolic disease in dogs with PLN. And so this idea, or this typical idea that, oh, PLN dogs are hypercoagulable because they lose antithrombin is not necessarily that straightforward. One of the other suggested mechanisms could be that albumin is a negative acute phase protein. So with more inflammation that we can see in many causes of PLN, more inflammation could predispose them to have thromboembolic disease. And we know that hypoalbuminemia is also a risk factor for thromboembolic disease in IMHA. So the other suggested mechanism is that a low serum albumin could cause an increased platelet sensitivity to activation. So this hypoalbuminemia could be really a direct increased risk for thromboembolism and not necessarily a marker of more severe disease. And the other interesting point was that this increased UPC was not associated with thromboembolic disease. So again, I think like the antithrombin activity, and that should not necessarily be used to predict which one is going to develop this complication. And so a previous study also did find this association in dog, and in humans, we also know that thromboembolic disease is not associated with the degree of proteinuria. And interestingly, the fact that they found the total leukocyte count, neutrophil monocytes higher with lower eosinophils in the group with thromboembolic disease. The discussion is that could it be a stress leukogram secondary to the thromboembolic event, or could it be actually a result of this inflammatory process, and an explanation why it was higher in this group. Let me quickly, we have a question here, a more general question. Should we continue the dogs on clopidogrel forever? Then I found it hard to justify and have the owners continuing the antithrombotics forever, and was basically tapering them once UPC albumin under control, but it seemed like we should just continue them. So that's a very good question, and I don't think that anybody has a clear-cut answer, because we don't even have great data of proving that it's helpful for the management. And so having data of when to discontinue is also a very, very hard topic. So I don't think that we have any great data to prove what to do. And that's why I was interested to have an input on what is everybody doing, and definitely more fuel for a discussion at the end of this presentation. So in the discussion, they're also talking about the most common location for thrombi. They found that the aorta was more common than the pulmonary circulation. So that's a little bit the opposite of what the curative consensus statement is talking about when they are discussing that the pulmonary circulation appears to be the most common location, followed by aortic thrombi. So definitely they are both the most, on the most common, but yes, this study found that aorta was even more common than pulmonary circulation. And in humans, we know that the venous thrombus are the most common in adults, but actually arterial thrombi are more frequent in children. And so the author also mentioned here that perhaps pulmonary thromboembolism may have been underrepresented because it's more difficult to diagnose antemortem than an aortic thrombi. And something that they discuss as well in the difference between the thrombus location is the age of the dog. So they tend to be older when they have arterial or venous thrombi compared to the one that have pulmonary thrombi in the pulmonary circulation. But this age difference did not remain significant in the multivariate analysis. And so one of the potential cause for these dogs being older could be potentially a reduced arterial elasticity and hypertension that could lead to endothelial dysfunction and be a nidus for thrombus formation. But definitely here, just a potential theory for a mechanism behind that. And the last thing that they talk about is the fact that venous thrombi are associated with increased cholesterol compared to thrombi in the pulmonary circulation, talking about the hypercholesterolemia recognized as part of the nephrotic syndrome, and describing that in humans, this serum lipoprotein levels correlate with total cholesterol level, and they are known to increase the risk of thromboembolic disease. And we know that lipoprotein directly promotes thromboembolic disease by inhibiting the activation of plasminogen and reducing the fibrinolytic activity, and decreased fibrinolysis has been associated with venous thrombosis in human. So all of that could be associated. So regarding the limitation of their study, definitely one of the big one was the lack of histological diagnosis for the renal diseases in the large majority of the cases. So we had only 8 cases with thromboembolic disease and 7 with non-thromboembolic disease that had a renal histopathology. And again, I'm not even sure which type of histopathology it was. And we know, at least from human medicine, that for sure the risk of thromboembolic disease varies depending on the underlying histological diagnosis. Their argument was that renal biopsies are not frequently performed, so they attempted to classify the dog with routine blood test and signalement to see if anything was popping out and helping us guiding or anticoagulation therapy just based on routine blood work and signalement. But definitely, they also described that further work to investigate underlying mechanism and the difference that were highlighted here definitely is needed to have more effective treatment recommendation. Of course, it was a retrospective study, so we had no standardization of the treatment or investigation, and even the persistence of the proteinuria was not confirmed in many cases. So some cases might have had transient proteinuria because of a systemic disease and not necessarily primary glomerular disease, so not something that they could have assessed because that was just based on one UPC. But interestingly, they are justifying that by the fact that, especially for the group with thrombotic disease, that would have excluded a lot of them because 30% of the cases did not survive their initial visit, which I think is actually a very interesting finding and probably one of the reasons why I am so proactive with anticoagulation. It's something that I think would have been interesting to highlight a little more and talk about the fact that these complications are definitely significant and can frequently lead to the death of the patient. So something that I think was sort of lost in the discussion here. They also talk about the fact of the potential misclassification of some of these non-thrombotic disease cases, because we only had postmortem examination in 4 cases. And for sure, they may have missed potentially an undocumented thrombotic disease. And their defense is that all thrombi that were identified postmortem were also identified during like routine imaging, and so, or were clinically suspected. So that's quite unlikely that they may have missed something postmortem if nothing when the patient was alive was leading towards the patient had a thrombus. And there was a higher proportion of patients with thrombotic disease that had a CT scan performed. So also something that they just discussed here in the discussion, and we don't have exactly any details of who had what, but that's one of the reasons why perhaps they may have missed a thrombus compared to the thromboembolic disease group that had more CT scans. And of course, there was a large amount of comorbidities and a small amount of each of these comorbidities, so that was likely underpowered to detect any small difference between the comorbidities to show up any significant difference. So to conclude the study, they are talking about the fact that the two main outcome of their study, they identified several factors associated with the development of thromboembolic disease in dogs with renal proteinuria, and they identified different factors associated with the development of either venous, arterial, or pulmonary thromboembolism. So if we remember the main finding that they had regarding the factor associated with the development of thromboembolic disease, the Cavalier King Charles Spaniels had a higher rate of thromboembolic disease compared to other breeds. Lower serum albumin concentration were also found in the case with thromboembolic disease, but definitely there was a large overlap, and we still had a quarter of the patient with normal albumin that developed thromboembolic disease. They emphasized also that the UPC was not useful to differentiate, and they found out that we had this higher total leukocyte count, neutrophils, monocytes, and lower eosinophils in the thromboembolic disease cases. So all the things that may highlight just on regular blood work. And regarding the difference in location, they found out that the arterial thromboemboli had a higher albumin than the venous cases, and that the arterial were older and had higher cholesterol than the pulmonary cases. So maybe highlighting a difference in the underlying disease process, but definitely the study was not powered to make any statement regarding the difference in the underlying disease process and how we should handle differently these different cases. And I think that concludes the study. Let me look on the chat. There's another comment from Daniel Gordon. I think the risk of thromboembolic disease outweighs the risk of bleeding in these patients, especially if only on Plavix. The cost of Plavix is inexpensive long-term. I think it gets tricky with the dogs that present with AKI and thromboembolic disease at the start, when to remove the anti-10A, etc., especially with the cost associated with those. So definitely agree with you. And I am also very much on the team of I'm very concerned about thromboembolic disease, and I haven't seen a lot of patients having complications from blood thinners, and it's much easier to handle the bleeding than a clotting issue. So I kind of agree here that I tend to start them very proactively and keep them long term, as long as their disease is not completely controlled, and generally we cannot completely control their disease. So I'm sort of on the same team here, but obviously we can open the discussion to anyone who wants to add their input or comment here.
Thanks, Emmanuelle. That was great. Really nice review, and the polls are really interesting too to get everyone involved. So that was awesome. I think regarding the author's comments that biopsies are not performed commonly, these studies, this one in particular, really highlights the need to biopsy, because as you mentioned, like there are different magnitudes of risk associated with thromboembolic complications, whether you have a membranous nephropathy, which is very high risk, compared to FSGS pattern, which is considered a lower risk when it's secondary. We treat everything as just based upon the UPC, and there are definitely going to be patients where maybe the cost and the low risk associated with anticoagulants might be greater than the benefits we get. And there are other patient populations that maybe need to get more robust anticoagulation right from the beginning, but that's going to likely be defined not just on their magnitude of the clinical parameters, but probably somewhat as to whatever the underlying disease process is that's driving their proteinuria. And even though when we're biopsying, we're seeing reactive patterns rather than diseases, it still might give us some clue as to how the immune system may or may not be upregulated in their problems. And that might help us determine, this is an NPGN pattern. This has a higher risk of thromboembolic complications, and there's a need for that, versus this is minimal change versus everything else that we do. So, I get everyone's, so many authors say like, well, we just don't do kidney biopsies that often, but until we actually start doing it, we're not going to get answers. I don't think just looking at these clinical pathologic parameters are going to be sufficient to tell us when we need to anticoagulate, because no study has done that so far. And I think we're still left with the same situation of, as Dan says, like, what are the risks and benefits? And for most patients, probably the risks are not that high with anticoagulation. And so I usually treat most of my patients, whether I biopsy them or not, with anticoagulants. And it just kind of depends. For me, if I'm seeing them for the first time that they're really being treated and their blood pressure needs to be controlled, they need to be on a diet, we need to get them off an ACE inhibitor and onto an ARB, then I'll probably do all that first, and then usually add in the anticoagulant as part of like their recheck visit, just so that I'm not completely overwhelming them, unless for whatever reason, if I have reasons to believe that that patient has a really high risk for seeing smoke in their atrium or anything like that. But that's just more of a hunch than anything that I would say that's clinically objective. But yeah, I think we need to kind of bury the limitation of, well, we're not biopsying these patients. I think biopsies are safe, especially for places that do them regularly, and they give us a lot of information. Certainly clients aren't going to be able to afford it always, and some patients aren't going to be stable for it, but that's just a big piece of the puzzle that we need moving forward to try to better understand the risks associated with these complications.
Absolutely. Thank you for your input. Marilyn, you have your hand raised.
Yes, thanks. Thanks for that, Emmanuelle. That was great. Maybe just raise again. I don't have any answers. Maybe just raise more questions. Is regarding thrombosis and the aorta, and some of the things, at least from the interventional standpoint, that we've seen is occasionally we'll have these patients that are presented. Some have PLN, some we're not able to identify, as you mentioned, in different studies, and that don't have PLN. But sometimes they're presented, and especially in the acute thrombotic phase, where we want to intervene, and either we'll balloon dilate, or if medical management or thrombolytics aren't functioning properly, or we'll go in and stent. And what's been reported in some of these cases that have undergone imaging is that not only they have a clot, but there seems to be maybe a stenotic or thickening of the wall, which could be, again, due to the thrombus. We unfortunately have postmortems in some of the cases that were stented, that died for other causes, or just didn't do well. And what's we found in a couple of these, and again, there's only one report that I'm aware of in JAVMA, and I can throw that into the chat. But is that we find atherosclerotic lesions in the distal aorta in some of these patients that have had stents. But the problem is that, could the stent have caused degenerative changes to the wall, or were these primary lesions? And one of the, there's a very recent JAVMA article that Dog presented with AKI, but it's more, what's interesting is, I can't put it there, is that there's atherosclerotic lesions in the distal aorta. And this was like a 10-year-old dog too. So I guess just kind of throw it out there is what we're seeing, at least from the interventional standpoint, with or without PLN, is that there seems to be some wall changes, and some of those wall changes may actually be primary. And as you mentioned, maybe endothelial dysfunction and atherosclerotic plaques are contributing to narrowing of the lumen and causing endothelial dysfunction, hypercoagulability, platelet reactivity. So it kind of throws out, cholesterol, older dogs. Could there already be maybe some primary vascular disease in some of these patients that then develop PLN? And so this is just, something else that makes them hypercoagulable, and one of the reasons that they're thrombosing in that one specific area. So maybe looking more into kind of the problems in lipid metabolism and primary, vascular lesions in these dogs too might hold some of the answers. So I don't know, just throwing it out there. I'd be interested in hearing others' thoughts.
Not a good thing to get old. It's the same for everyone. But yeah, absolutely. That would kind of make sense to start to have this accumulation of comorbidities. And I think that that's what the authors tried here as well. But definitely we may have to, sort of take a step back and have a more specific study on cases that were truly diagnosed, that we know what is happening, at least at the kidney level. I think it may be even harder to have a diagnosis of what is happening in their vessels, and having a good description of these specific cases before describing a population with like a ton of different comorbidities, and that could for sure add other complicating factor to the process here. Thank you for the link, Marilyn. Great. Anybody else has anything to add to the chat?
Great presentation. Echoing here.
Thank you. Great. Thank you so much then for everyone to show up for this presentation. I hope that you learned something. It's always good to see or to have at least all of you part of this. And I really enjoy this journal club. It's always very good information. And I thank all of you for your participation.
Thank you so much.
Have a good rest of your day. Bye, everyone.
Thank you.